Good morning. Call this roundtable of the Committee on Health to order. Today is Monday, September 11th, 2023. The time is now 9:30 a.m. I am at-large Councilmember Christina Henderson, Chair of the Committee on Health. Today, we're holding this oversight roundtable to hear from the public, our three Medicaid managed care organizations, Mila Kaufman, who is the Director of the Health Benefit Exchange, and Melissa Bird, who is the Interim Director of the Department of Healthcare Finance, about the ongoing unwinding of Medicaid continuous enrollment during the COVID-19 pandemic. After 3 years, when Medicaid enrollees were not required to renew their benefits, Medicaid renewals resumed on April 1st, 2023. The Committee on Health held an oversight roundtable to discuss preparations for those renewals on May 4th, 2023, with experts and our government agencies. In the 4 months since that hearing, we have observed substantial challenges in renewing Medicaid enrollees insurance coverage. In DC, of the 67,537 renewals that were due through the end of July, only 43,271, or 64%, were successfully renewed as of August 11th. These challenges have not been unique to the district. Nationwide, since April 1st, more than 5.5 million Medicaid enrollees have had their coverage terminated. During the period of continuous coverage, Medicaid enrollment grew by approximately 20%. Now, more than 28% of individuals are subject to coverage termination. This raises concerns that some individuals who are eligible for coverage are not having their coverage renewed. This is especially concerning when we see that of those in line to have their coverage terminated, 90% are of procedural terminations, meaning they are being terminated from Medicaid because they didn't respond to the renewal application notice. My hope for today's hearing is to hear about what aspects of this process is going well, discuss what is going poorly, and look for solutions to ensure all of our eligible DC residents are enrolled in Medicaid coverage. We will also use this hearing to highlight other health insurance options for DC residents who are no longer eligible for Medicaid enrollment. For those residents who receive renewal notices, please complete and submit your renewal application. If circumstances have changed, i.e., you're no longer eligible for Medicaid because you're receiving insurance from your employer, connect with a health benefit exchange, also known as DC HealthLink, to make sure there isn't a period for which you don't have a health insurance coverage. You can find more information about DC HealthLink at dchealthlink.com or by telephone at 855-532-5465. With that background, I will now turn to our first panel of witnesses, which are representatives from our three Medicaid MCOs, Adrian Jordan, who is the plan president and CEO of AmeriGroup DC, Karen Dale, who's the market president and CEO of AmeriHealth Caritas, and Leslie Lau Smith, who is the executive director of MedStar Family Choice District of Columbia. They are actually here with me in the chamber. So if you want to come on up. Good morning to both of you. I'm told that Mr. Jordan is stuck in traffic, but he's on his way. So Ms. Dale, why don't you go ahead with your testimony? Oh, you just have to turn on the mic in front of you. There you go.
Sure. Good morning, Karen Dale, Market President and CEO for AmeriHealth Caritas District of Columbia. We've proudly served for a decade, approximately 120,000 district residents. And we are most proud of how we are embedded in the community, our level of engagement and support. During the pandemic, we were able to maintain contact with many of our enrollees, continue to provide care management support and virtual classes in order to ensure people had the support they needed to be healthy and maintain well-being. Our team is dedicated and committed to being in the community, so we are embedded at a number of provider sites, which enables us to provide immediate assistance and support to our enrollees. We're also very proud of the programs that are very specific to maternal health, adolescent mental health, and the focus on addressing the needs of people living in more under-resourced communities who are more often going to have incidents of diabetes, hypertension, cardiac disease, and a number of things that come from not having access to healthy and available food close by. So we have a whole series of things that we do to support food as medicine, including home meal delivery, grocery delivery, in-home services around nutrition, grocery shopping, cooking, all those types of things, so that we are getting further upstream in how we support our members' health and well-being. We're also very proud of how we center around the voice of who we serve. We have 2 member wellness advisory councils, one for adults and one for adolescents. So through the pandemic, and now as the unwinding begins, we have maintained those tenets of who we are and how we engage with the community we serve in order to help improve their well-being. Our efforts around the unwinding include proactive efforts to look at who is coming up for redetermination. We have social media, ads in the newspapers. We have a lot of outreach calls that happen and text messages in order to alert people that they're coming to redetermination. We also work very closely with our providers. They have access via a portal in order to see who of their patients are coming up for renewal. And we've gone out to provider offices to help them to know how to pull those reports. We also send it to them proactively. In addition, we have embedded teams, as I mentioned, who are at the larger provider volume sites so that they are there to also assist our enrollees. At our wellness center, we have staff there so that our members can drop in and get the assistance they need. We have a computer and a printer there so that people can come there to do their enrollment if they're not, and get assistance if they're not able to do that on their own. Finally, we have a lot of one-pagers that we have sent out to our community-based organizations with whom we work, as well as providing that information to our provider offices. So it's a reminder for the providers, but they can also give it to their patients in order to assist them. So we do know that there are times where someone gets disenrolled despite their best efforts. In those instances, we have a couple of processes in place. The first is when someone is disenrolled and calls us and says, I'm at the pharmacy or someplace needing, their necessary medical care. We do ask them and try to understand where they are in the process. So did they remember to enroll and they just haven't heard back? Or have they engaged with ESA by submitting their application? Once we have the important information about where they are in the process, we do reach out to ESA for their assistance in locating where that person's application might be. In the meantime, though, if we do believe that that person should be, or ESA believes they should be re-enrolled, we are able to then reach out to the providers, and in a short amount of time, the contacts that we have at ESA are able to get the person re-enrolled in their MMIS system, which allows for us to then have a conversation with the provider or the pharmacist so that the person gets their medication or whatever needed service. We work very hard to ensure that we are identifying and stratifying our most vulnerable members in terms of outreach. So we do a lot of work for everyone, but particularly for those persons that might need something like dialysis or their insulin, making sure that we are doing as much as possible with all the contact information and provider claims information that may help us to understand where they might show up so that they are able to get what they need. So we know the unwinding continues, and we take very seriously that the 120,000 plus people we serve deserve our best efforts in order to get the best health outcomes. And so we continue to work with our providers, Department of Healthcare Finance, the Ombudsman, and ESA to make sure their needs are met. Thank you.
Thank you, Ms. Dale. I'll have some questions for you. Ms. Smith? You just turn on your mic. Ms. Dale, if you could turn yours on. There you go. Great.
Good morning, Chairman Henderson. I am Leslie Lyle Smith, Executive Director of MedStar Family Choice, District of Columbia. Thank you for the opportunity to present an overview of our Medicaid renewal efforts. We consider this initiative extremely important to ensure our vulnerable enrollees keep their health benefits. In April of 2023, MedStar Family Choice District of Columbia convened an internal work group of subject matter experts for the purpose of developing and implementing solutions to mitigate the impact of pending Medicaid redeterminations. The work group meets biweekly and is chaired by our Director of Operations, Cleveland Woodson, and planned functions represented include, but are not limited to, our outreach, marketing, community relations, data analytics, communications, medical affairs, care coordination, and provider relations departments. Virtually, our whole health plan is involved in this effort. Through the efforts of this work group, we've implemented a number of outreach strategies to ensure our enrollees maintain their benefits. Since April, we have undertaken greater than 107,000 distinct outreach tactics to mitigate the impact of redetermination, mostly outbound and interactive voice response telephone calls. We have partnered with the Getty Group, a certified business enterprise, to supplement the efforts of plan staff in conducting telephone outreach to enrollees whose benefits are scheduled to terminate. Based on the latest data report representing June 27th through August the 29th, we have placed close to 11,000 telephone calls to enrollees and connected with 994 who we assisted in renewing their benefits. This represents a success rate of about 9%. Unfortunately, telephone calls results in multiple barriers, including wrong phone numbers, disconnected telephone numbers, and phone calls not answered. Among the reasons enrollees who are able to be contacted were not interested in renewing their benefits was that the enrollee has commercial insurance now, or that the enrollee has moved out of the district. However, many enrollees that we contact are still unaware of the need to renew. An enrollee contacted in August was completely unaware of the need to renew benefits since he recently underwent heart surgery. The enrollee, however, was grateful for the telephone call and pledged to complete renewal by the end of the week. A follow-up call was placed to remind him, and I'm happy to report that he's now re-enrolled due to our outreach efforts. Additional tactics includes banner ads on our web plan website, live discussions about redetermination during our monthly new enrollee orientations, on-hold messaging when enrollees call into the call center, and all MedStar Family Choice associates are expected to remind enrollees during all enrollee interactions about the need to renew their benefits. Other outreach tactics include text messages. To date, our outreach team has sent more than 4,500 text messages. The retention or open rate of these messages is about 57%. 78 enrollees responded yes, indicating they needed assistance with renewing their benefits, resulting in the outreach team providing real-time assistance. The outreach team also programmed over 5,100 IVR or interactive voice response calls through our vendor care message. 1,042 enrollees listened to the entire message, with the difference attributable to either no response or bad phone numbers. Excuse me. Our communication team has posted multiple entries on our plan's Facebook page about redetermination. In addition, the communications team has sent several provider alerts about redetermination, including a full-page article based upon the DHCF toolkit sent in early August, with plans to send out monthly provider alerts and reminders. All MedStar Health provider offices and DC hospitals have notices posted and trained staff to assist enrollees in renewing. An enrollee newsletter with a message about redetermination from our plan's chief medical officer, Dr. Raymond Tu, was mailed to over 45,000 heads of households. Printed collateral materials are available at all community events and affords us the opportunity to educate and assist enrollees on how to renew. Staff are trained on District Direct and to assist enrollees. Despite these efforts, MedStar Family Choice has experienced about an 8% enrollee attrition rate since April. This causes us to explore other outreach strategies, including door-to-door for those enrollees that can't be reached and for those enrollees that have terminated in order to get them to renew during the 90-day grace period. MFC has appreciated the many webinars provided by DHCF on redetermination, training on District Direct, and collaboration at community events. An opportunity to have more real-time data provided by DHCF in order to ensure more targeted and timely outreach opportunities. Moreover, the demographic data for many enrollees is not up to date, which makes it difficult to effectively reach enrollees. Again, this redetermination process is extremely important to ensure our enrollees' care and healthcare needs are not disrupted. MFC will continue to aggressively pursue outreach tactics to ensure minimal disruption. Thank you, Chairman Henderson and the committee members for this opportunity. I'm happy to address any questions.
Thank you. Mr. Jordan?
Good morning, Chairperson Henderson and members of the committee and council. My name is Adrian Jordan, President, CEO of AmeriGroup DC. I want to thank you for the opportunity to testify today on AmeriGroup's efforts and role in the district's Medicaid renewal and redetermination process following the end of a once-in-a-lifetime public health emergency. As you know, AmeriGroup is one of the 3 managed care organizations that serves the district's healthy family and alliance population, and we currently serve around 71,000 residents. AmeriGroup began preparing for Medicaid renewal after the federal government announced the phase-out of continuous eligibility requirement. We began engaging with the HCF on the operational plan they would undertake to best align our efforts with the districts. We also remain cognizant of the forthcoming redetermination process and our partnerships with local CBEs in order to source additional resources we may need for community outreach. At the same time, AmeriGroup began providing healthcare coverage this past April. The district began sending notices to residents about their Medicaid recertification dates. As such, our efforts have been intertwined from the start, and we've made every effort to be in lockstep and a good partner with the district. Like DHCF, AmeriGroup has taken a number of proactive steps across different platforms to outreach in an effort to ensure our members are as informed as possible around Medicaid renewals, the possible loss of coverage, and the actions they need to take in order to remain covered. Some of, but not all of our actions include launching our own branded Ready, Set, Renew campaign, the goal, which is similar to the district's Don't Wait, Update, and Act Now and Stay Covered, to direct enrollees to District Direct to receive information about redeterminations and how to renew their benefits. We've also completed close to 100 events and outreach efforts focused on educating and providing information on Medicaid renewal, conducting outreach through text. We've sent over 6,000 to date, telephone calls over 2,000 to date, and direct mails. Securing print and radio advertisements and interviews for members of our senior leadership, as well as partnering with our community organization. And lastly, collaborating with the other MCOs through the Managed Care Partnership Collaborative to bring a bigger voice and cast a wider net on our renewal efforts. In addition to our proactive efforts, AmeriGroup stays abreast in the district's actions through, among others, DHCF's biweekly Medicaid renewal meetings. This meeting has been useful in understanding district decision-making, data trends, and how we can be strategic partners. And we also hear from the concerns of our stakeholders. As Medicaid renewal and redetermination progresses, we remain ready to partner and to be considered a valued resource to the district. With that, that concludes my brief remarks, and I'm happy to answer any questions you may have today.
Thank you. Thank you to all 3 of you for being here. I think this is the first time we've had everybody together since we've done a transition. So welcome. We'll be talking more, I'm sure, on other things. Ashley, if you could put me on a 10-minute clock. I don't know if any of my other colleagues are going to join us, but I like to keep myself on a clock just to stay focused. So thank you again to all of you for being here and for your particular efforts. I have a couple of follow-up questions just to sort of understand a little bit more what are some of the challenges that you all may or may not be facing. So Ms. Smith, you were I think the only one to say what your attrition rate has been, which is 8% of enrollees since April. Ms. Dale, what has AmeriHealth Caritas seen? If you turn your mic on.
7.2%.
7.2%. That's since April?
Yes.
Okay. Mr. Jordan?
And I don't have an exact percentage, but I know we've lost approximately around 5,000 members, so it'd probably be in the same 7 to 9% ballpark.
Okay. Is this what you all expected? So when I look at the charts for the information that we have from DC Healthcare Finance, right, we went from a little under 200,000 Medicaid folks pre-pandemic, and then we crested above 250,000 during the continuous enrollment period. So we anticipated that some people in that margin likely were not going to be eligible for, they got a job, they moved, all of the various changes that can take place in 3 years. In terms of the numbers that you all are seeing, is this something that you anticipated in your work? Whoever wants to go first.
Yes, the national estimates in terms of Medicaid growth were approximately 20%. So we thought at least somewhere between 9 and 20 would be appropriate in terms of what we might lose. So those were estimates that we felt were in the range where we are right now.
Okay.
Yes, however, we estimated about a 10%. So somewhere in the middle, and it's turning out to be a little higher than that.
Okay. Mr. Jordan?
Yeah, and I would concur with that assessment as where we are in the renewal process for that. Yep.
Okay. Ms. Dale, in your testimony, you talked a little bit about you all providing providers with access to a portal that alerts them that, hey, the patient who's coming in for this particular appointment, it's time for renewal. Is this a portal that was set up by Healthcare Finance, or was this something that you all put together yourselves?
This is our usual provider portal that our providers go to check claims status,
Okay.
gaps in care, et cetera. So that's where they go. And since we have pretty good utilization there, we thought that would be an appropriate place to put the content and the pop-up and the list that they can run to identify people.
Okay. So it comes as a pop-up. So when you log on and you're
Yep.
like, hey,
Yep.
Okay,
So
wonderful.
it's both. It's a pop-up for that patient when you check eligibility,
Okay.
and then they can pull a list so they can look at their full patient panel that might be due for recertification in a given month.
Okay. Do you think that this is effective in terms of communicating to patients who may have been missed through other traditional means?
Yes, that in addition to the one pager that reminds them about the steps in the process.
Okay. Do any of the other MCOs communicate with providers about status that could help perhaps when you come for your, the well child visit, now you have the pediatrician who's also reminding you as well?
So we don't have the technology that Ms. Dale has indicated. However, we have educated our providers regarding the fact that many of their enrollees will redetermine and taught them how to find that information so that they can be aware if they have an enrollee that comes through that needs to be redetermined.
Okay. Mr. Jordan?
And yes, we work with our provider relations team to educate our providers on the initiatives that we're doing, as well as the district. And when we have wellness events with our providers and FQs, we have our sandwich boards and we have our Ready, Set, Renew campaign where someone can use a QR code and it can walk them through the steps of how to determine eligibility, what they need to do to redetermine. And we can track metrics to do that as well.
Okay. So one of the things that when I talked to Healthcare Finance about this before with their data team, obviously we know a lot of people moved or we know that their information is wrong, but also let's say you do get in contact with someone like you were talking about, Ms. Smith, in terms of like 11,000 phone calls that your folks have been doing for the folks that you do actually speak to a human and they say, I'm not interested because I have a new insurance. Is there a mechanism where you can communicate that information back to Healthcare Finance so that those folks are no longer in the pool of folks that we're trying to reach? Like what happens if you know, Ms. Dale, that someone has physically moved? Can we mark, hey, no longer live here? I mean, I know that can get a little tricky because we don't want to have this necessarily be a subjective process where we're removing people who haven't in fact moved, but we just can't find. But I feel like if you have a confirmation that someone either has gotten their own insurance or they're no longer living in the District of Columbia, it helps to clean the data a bit. Is there an option for communicating that back? Oh. There you go. You're on.
So DHCF does have a process where we can communicate back to them when there has been a revised phone number or updated phone number. So we do provide that information to them. And then our expectation is that their system is updated accordingly.
Okay, that's updated phone number, but what if someone?
Address or phone number, or moved out of the area.
Okay, but what if someone says, I already have insurance?
So that part, we don't have a direct process for.
Would that be helpful? I don't know. I mean, we're kind of several months into this process, but I'm just trying to I want to have a better idea of who's out there who needs Medicaid versus who's out there who they had Medicaid, a need at one time, and they have moved on to something else.
I think it would be helpful to have more, as I indicated, more kind of real-time information that flows both ways. So definitely, I think that it would be helpful. Okay.
To put more context around your question. The district, I believe, intends to ask CMS for us to be able to update information when it is not coming directly from the enrollee, right? So we can report what we have heard. It would still need to be verified by that person, because anyone could say, right? So that's one step, is that you can't just say that as a third party versus having the person report that information directly.
Right. I'm
So we
saying if
usually-
you reach that person.
Yes, yeah.
And they
So-
have said,
And when they do, we usually ask them to report or update their information so they can call ESA, or they can create an account and update their information. That is the most valid way of ensuring in a timely fashion that the information is updated. So all those methods could be used, but the best way is for the enrollee to create an account on District Direct and go in and update it, because then they can update it whenever it needs to be updated. Something else changes, they lose their job. That's probably the best way to ensure that information is maintained most accurately, is to have the enrollee do that themselves. And it's very easy, the steps to go into District Direct, create an account, and that way, whether they move or have a different phone number, they now have an account. That's their mechanism for communicating directly.
okay. If you had to say one thing that could help improve this operation on your side for the folks who are doing this outreach, what would it be? Whoever wants to go first. Okay, the top two. If one is, it's too difficult.
I always have some. So
Okay,
the opportunity is to have more public information in the places and spaces where district residents are, right? So for example, when we first started, some of the first people that reached out to us, it was when they went to the pharmacy and realized they couldn't fill their prescription, that they were like, they checked for eligibility and I didn't have coverage. So our immediate response was to go to look at our claims and go to our highest volume pharmacies and speak with every shift of pharmacists to remind them to give people the information about District Direct. And so I think, and recently, maybe about a month ago, I was in CVS, right? And CVS now had overhead messages every so often between the music that said, if you are served by a Medicaid program, you should, right? So that's to me the opportunity we, all of us have, is to figure out those best places and spaces. Like I would love for the grocery stores to have a message, right? Like how do we leverage? The district is small enough that I think we have a real opportunity to ramp up on our campaign in places where people tend to be.
okay.
And I would agree with Ms. Dale in that getting the information out in places that our enrollees live, play, and work. So even in their housing developments, if we could have information there, or the housing authority could have information, just really inundating the community with information about what to do.
Okay. Mr. Jordan?
Yeah, and I echo that. I was going to say more time to reach the thousands and thousands of enrollees that we have who may have moved and we don't know where they are, to identify them. But in addition to that, potentially, and I've seen this anecdotally, the ability to assist our enrollees with continuing to fill out the application for renewal. I've seen enrollees come through the Wellness Center, and we have our Ready, Set, Renew campaign where they can go on and do it, but we don't know if they completed it and what the status is once they leave the door. So just knowing that we were able to see it from beginning to end would probably, but anecdotally, in addition to time, be very helpful as well.
Yeah, we just recently did a webinar for ANC commissioners in terms of how they can help support, residents in their SMD who need to renew. And even just sort of explaining like, what are the documents or information that someone needs to complete the process so that you could be prepared at the front end. What does the envelope look like when you receive that notification, and then those kinds of things. Let me just check if any of my, okay. So I have one more question and then I'll let you guys move on. I've learned through this process and this work that your organizations have an incredible amount of data on individuals from a variety of different metrics, standards, et cetera. And one of the things that could be an indicator, is utilization data. And so I'm curious if you all, your data teams have done some mining to determine for individuals who have moved off the rolls, was it had they used their insurance within the last 6 months or 8 months or a year, or was it dormant and inactive for a while? So I'm just curious, are there things that we can learn from utilization around whether or not someone may have moved or may have sought other insurance otherwise, especially for individuals who you have diabetes. So you had been getting regular prescriptions and then it just stopped, or you have some other type of treatment where you had been having regular doctor's appointments and then it just stopped.
So yeah, and I mean, we see everything from no utilization to pharmacies that are in California. But one of the things that our team, what we do, we look for those who are going to be on the term file for the month, but we also see who's used an ER, who's gone for a well child visit, who has a chronic condition, and we do extra outreach to those folks because we don't want those people to fall off the rolls because they are utilizing care.
Right. Okay.
And same thing, particularly as I mentioned, we're looking to target door-to-door outreach. And so what we want to do is look at those that may have termination dates and look at their utilization so that we can prioritize, who to outreach to first, so that we can ensure that their benefits renew. And those that likely didn't have any utilization, we'll put those at the end of the list to outreach to.
Ms. Dale?
I want to put some context around utilization. In this work that we do, we're dealing with human beings, right? And behavior patterns that change. So it's not always a direct path. So here goes. There are people who are appropriately utilizing services and may reach a point where they may only need to have an annual physical, or based on what we want people to have, like someone over 50, we want them to have a shingles exam, right? Or they have their mammogram. And so their utilization patterns look different. And then you have people who in their health and wellness journey are a bit resistant because it's a process of acceptance that someone's told you have diabetes, right? So I don't want us to over-index on utilization as data because it depends on where that person is and their care team is. I agree with everything my colleagues said about focusing on those people who are most sick so that we give the most intense effort to ensure that they remain connected. As we look at our data, we see that people who are more well are the ones that are rolling off so it's not saying they haven't engaged in care, they have.
Mm-hmm.
And so we don't know all the reasons why, is it they moved out of the area? they are, they have other insurance, they're now employed. We're not sure of all those reasons, but I just wanted to give a little context so that we don't over-index on what utilization means, because there's appropriate utilization, less appropriate, but what we have seen is people who have more appropriate utilization or no utilization are the ones who are not necessarily re-enrolling.
Yeah, no, I appreciate that. And thank you so much for adding that additional context. I guess I'm thinking back to a hearing we did prior to recess on prior authorization, or the hearing that we did on opioids. And where the place where most people find out that they don't have coverage is at the pharmacy when you are trying to get your refill. And what can that mean for someone who is reliant on that medication for daily function, right? And so, let's say the pharmacist tells you that morning, oh no, it says you're no longer covered. How long then does it take that person to go back through the process and then get back on track? And what happens, excuse me, what happens in that interim period? So that's why I was sort of thinking about from a utilization standpoint. For those who you say the very sick among us, or the ones who are having regular use of medications, I want to make sure that we're getting to those folks so that the moment isn't at the pharmacy when it's like, but I need this, or else I may spiral, have an episode, or do it, whatever, XYZ. Our teams are good, but I don't think I've ever seen anyone get back up on coverage in less than 24 hours. And then all of it just sort of run right back through. But thank you again. I don't have any further questions for you all. I'm sure we'll continue talking as we go through this process. I will say this, even looking in terms of the attrition numbers and hearing what's happening around the country, I'm glad DC is not where other places are in this regard. Even so bad, whereas some jurisdictions, CMS is telling them to stop, like just don't do it anymore. But this is a partnership area where we got to keep working on it together. And so I thank you all for your efforts and your teams for their efforts to helping as we get folks back re-enrolled. Yes, Ms. Dale.
So in that regard about CMS's guidance, I am pleased to say, and I'm sure it'll come up maybe in DHCF's testimony, that we did halt disenrollment of children,
Yes.
which is really important. And I think it gives us another opportunity around upping our efforts around communication. And I would love to see that kids are great messengers, right? That we would partner in some more intensive way with OSSI or whomever is most appropriate, again, as another point to get the word out.
Yeah, I was actually thinking in some areas, how can we work better with, say, children's, especially since it's back to school immunization time. And this is an excellent opportunity to remind some families. But thank you all so much again. And if you haven't sent us your written testimony, can you please make sure that the committee gets a copy? But thank you, you're excused. Okay, so we're going to move on to our next panel of witnesses. We have 5 public witnesses, and they're all, this group is all virtual. So I'm going to call all 5, and then we'll go from there. Jakia Carroll, Andrew Patterson, the Senior Staff Attorney for Legal Aid Society of DC, Claudia Schlossberg, Lindsay Niles, who is Managing Attorney of Disability Rights DC at University Legal Services, and Tamara Smith, who is the President and CEO of DC Primary Care Association. For those of you who have not participated in a virtual hearing with us, you have to affirmatively accept our invitation to join. And we will give you guys a moment to come into the room. Okay. Jakia Carroll? All right. Andrew Patterson?
Yes, can you hear me?
Yes.
Thank you. Good morning, Councilmember Henderson and members of the Committee on Health. My name is Andrew Patterson. I'm a senior staff attorney with the Legal Aid of DC. We appreciate the efforts of the Department of Healthcare Finance and the Department of Human Services staff to ensure that the return to Medicaid renewals is done in a way that protects beneficiaries. We also appreciate the information DHCF has shared about the number and percentage of beneficiaries who have renewed their Medicaid, including the number of people who are due to recertify each month, broken down by different eligibility groups, as well as the number of actual completed renewals in those groups. The most recent figures provided by DHCF do raise some concerns about the number of Medicaid enrollees who have not been able to successfully renew their coverage. You went over the average of about 64%. And as you also noted, many of these terminations that are happening are done for procedural reasons. That is not because they are not eligible for Medicaid. We are also concerned that DHCF's figures show that the completed renewal rate for some eligibility groups is much lower. According to DHCF's numbers, only 36% of the recipients of age, blind, and disabled or long-term care Medicaid who initiated their renewals between May and July were able to successfully renew their coverage. ABD and long-term care Medicaid groups are some of the most vulnerable enrollees in the district's Medicaid program and are at much greater risk of injury or health complications if their access to care is interrupted by losing their coverage. Many beneficiaries who are enrolled in the district's long-term care Medicaid, such as the Elderly and Persons with Physical Disabilities or EPD waiver program, rely heavily on Medicaid-funded services, especially personal care aid services, to complete even basic activities of daily living, such as walking, eating, bathing, dressing, and toileting. If waiver enrollees lose access to their personal care aids, they may attempt these activities on their own, increasing their risk of injury. Legal Aid is pleased to make a few recommendations designed to increase the number of individuals who are able to keep their Medicaid without interruption. First, we encourage the council and the mayor to ensure that the Department of Human Services and Economic Security Administration has the necessary personnel to process renewals on time. I recently helped an elderly Medicaid recipient submit her renewal documents a week before her scheduled termination. When I called to check on the status of her renewal, I was told her Medicaid would still likely terminate since it takes 45 days to process the renewal. This has resulted in a hearing request needed to preserve coverage while the renewal is being completed that could have been avoided if the renewal had been processed on time. These types of delays in processing documents for Medicaid renewals have been a problem for years, and we therefore encourage the council and mayor to ensure that DHS and ESA has the staffing necessary to process all timely submitted renewals, even those that may be submitted close to the termination date. Legal Aid also endorses the proposals made by the DC Coalition on Long-Term Care in a recent letter to DHCF with respect to changes that would specifically address renewal rates among long-term care Medicaid enrollees. Among the proposed changes were granting access to the DC Direct Partner Portal to beneficiary designated assisters. The current rules allow only EPD waiver case managers to submit renewal documents for their enrollees, while stating that other people may assist enrollees with parts of the renewal process, such as gathering required documents or proof of changes. We urge DHCF to reconsider this position. Long-term care Medicaid enrollees often have relationships with people in medical providers' offices, case managers, social workers at core service agencies or other providers, and others who would be willing and able to help them not only gather information, but actually submit renewals online. Indeed, an enrollee in most Medicaid programs can log into their district direct or share their login with a case manager or a designated representative they trust and have that person upload necessary documents on their behalf. This change would be particularly useful for the long-term care Medicaid population because they are more likely to have difficulty understanding the long renewal forms, some of which are dozens of pages long, and may be less familiar with or have less access to some methods of renewal, such as online submission of completed renewals. It would also benefit those long-term care enrollees who cannot trust their case managers to complete the renewal on time because, again, as noted in the coalition's letter to DHCF, there does remain a problem of non-performing EPD waiver case managers who do not timely complete and submit renewals. There's a couple other recommendations in my testimony, but I'm almost out of time, so I'm going to just submit those for the record. And I want to thank the committee for your commitment to ensuring that the district's Medicaid program works for all eligible district residents, and for the opportunity to submit this testimony. Thank you.
Thank you, Mr. Patterson. Ms. Schlossberg?
Thank you, Councilmember Chair Henderson and the Committee on Health for the opportunity to testify and share remarks regarding the status of Medicaid renewals. My name is Claudia Schlossberg, and today I am testifying and offering my remarks as the convener of the DC Long-Term Care Coalition. I want to focus primarily on the impact of the renewal process on the 63,000 district residents whose Medicaid eligibility is determined using non-MAGI income methodologies. As I testified on May 4th, the non-MAGI cohort, which includes 33,000 seniors and people with disabilities, including nursing home residents, and individuals who receive services through the EPD waiver, are at greatest risk of losing Medicaid coverage. Unfortunately, the experience to date shows that the district's Medicaid renewal rates are lower than DHCF had predicted in May. And in fact, the non-MAGI cohort, including individuals with disabilities and those over age 65 who rely on long-term care services and supports, are losing coverage for procedural reasons at far higher rates than other beneficiaries. According to DHCF's latest renewal report for the period May through July, the aged disabled LTC cohort makes up 40% of non-responders, whereas the overall non-response for all beneficiaries is 26%. While these figures for this aged disabled LTC cohort are not yet available for those with termination dates of July and August, the DHCF renewal dashboard as of August 11th shows that 32% of the beneficiaries with Medicaid termination dates as of July 23rd were terminated for non-response, while 49% of the beneficiaries with Medicaid termination dates as of August 1 will potentially lose their coverage for non-response if they do not complete the process within 90 days. These terminations have immediate impact on the ability to receive ongoing needed health care. Once terminated, however, the providers serving them are not paid until the beneficiary's renewal is completed and approved. Additionally, on the day that Medicaid eligibility ends, EPD waiver providers such as assisted living providers, home health agencies, and adult day health who are providing ongoing care to our seniors also immediately lose access to the beneficiary's information in DC Care Connect. This includes information such as their person-centered plan of care and information about the assigned case manager and case management agency. At this point, case managers also are not able to bill for their services, yet due to policy decisions made by DHCF, only the assigned case manager can upload completed renewal forms to the DC Direct Partner Portal, which DHCF has confirmed is the only place where a renewal for long-term care services and supports can be submitted. With limited access to information about the beneficiary's status and no ability to submit forms on a beneficiary's behalf, providers are spending hours making phone calls, sending emails, and elevating cases to DHCF staff to try to resolve eligibility and renewal issues and secure prior authorizations needed to continue services. Even once approved, there are still delays and errors in getting program codes updated timely and correctly, getting service authorizations approved, and getting systems updated and in sync to reflect accurate program codes. It's unclear if these are system issues or due to human error. We are hearing as well from providers that when issues occur and are escalated to DHCF, it is taking much too long to get resolution, even though we know that staff are working very hard to address the issues. We are also hearing that initial applications for Medicaid are taking longer than 45 days. We've communicated with Director Byrd, and we are pleased in her response, which I've included in my testimony, that DHCF is considering, using emergency gap authorization for providers in situations where a person cannot complete recertification, but services were delivered in good faith, and we're looking forward to hearing more about this. We also have a meeting coming up with her later this month, and we hope to submit and discuss some of the recommendations we made both in our letter and which I've included in my testimony. There is a need to add functionality to the DC Direct portal to ensure that applications and renewals for long-term care Medicaid can be uploaded into that portal so that beneficiaries with assistance from whomever they choose are able to complete the renewal and submit renewal forms. They also need to reprogram DC Direct, the partner portal, to allow providers to access DC Direct partner portal, to access that portal so that they can also upload information. Until the changes are made to allow more pathways for submission of application and renewal forms for individuals receiving long-term care, DHCS needs a specialized backup team that can provide the case management services or do the things that case managers are now tasked with doing on a temporary basis so that renewals can be completed. We also believe that DHCF must reprogram its systems to ensure that providers do not automatically lose access to DC Care Connect for beneficiaries who remain in their care following a termination of eligibility. A possible way to do this would be to reprogram the computer system to maintain access for a period of 90 to 100 days following termination. Doing so would help support safe transitions of care, even in the event a beneficiary is determined ineligible for continued Medicaid. We also have recommended that DHCF redesign the eligibility forms to reduce the number of pages. It's now 44 pages for a renewal application plus 18 additional pages for long-term care, and to eliminate the redundancies. I've included other recommendations in my testimony as well as in our letter to Director Byrd, and I'm happy to answer any questions. Thank you for the opportunity to testify.
Thank you. Lindsay Niles.
Good morning, Chairperson Henderson. My name is Lindsay Niles, and I'm a managing attorney at Disability Rights DC at ULS. DRDC appreciates the opportunity to testify. DRDC is a designated protection and advocacy program for people with disabilities in DC. My testimony focuses on the adverse renewal outcomes for Medicaid long-term care beneficiaries and our recommendations on how to improve outcomes for this population. You may also refer to my written testimony, which addresses these areas in detail. DHCF has structured its Medicaid renewal process in a manner that is inaccessible to people with disabilities and excludes most non-MAGI Medicaid seniors and people with disabilities from the passive renewal process. Because DHCF transitioned to an updated district direct eligibility system without transferring long-term care beneficiary information into the updated system, DHCF requires people with disabilities to submit longer renewal forms than people without disabilities. As a result, CMS recently found that DHCF is out of compliance with the renewal requirement that DC conduct ex parte renewals for the non-MAGI population. DHCF should streamline renewal forms and requirements for this population and manually enter information into District Direct. Additionally, long-term care or waiver beneficiaries are not allowed to submit renewals on their own and must rely on a case manager to do so. DHCF has acknowledged that case managers are failing to submit renewals timely, as some of my colleagues have previously testified. As a result of DHCF's renewal procedures, there's a low renewal rate for people with disabilities. At a rate of 36%, this population from May to July had lower renewal rates than other Medicaid groups to date. This means that 64% of non-MAGI beneficiaries are facing termination. We applaud DHCF for granting a 30-day eligibility extension to allow more time for non-MAGI beneficiaries to submit a renewal response, including 2,100 people due in August that face termination. However, this flexibility has not ensured continued access to Medicaid services for all those beneficiaries who seemingly remain eligible. DHCF has reported that approximately 1,600 non-MAGI seniors and people with disabilities due in June and July were procedurally terminated from Medicaid. Of those 1,600, the result of case manager inaction is that almost 200 EPD waiver beneficiaries are losing Medicaid eligibility for procedural reasons. As reported by the Washington Post in August 2013 and 2012, approximately 300 EPD waiver beneficiaries were terminated from DC Medicaid for procedural reasons. At DRDC and other advocacy groups urging, DHCF identified those individuals and found that 133 of those terminated had died and 37 had entered nursing facilities or other long-term care facilities. The devastating risks of these procedural terminations cannot be understated. DHCF should increase staffing to provide one-on-one help to recertify everyone who have not responded, including door-to-door outreach by Liberty Health nurses, along with case managers. We recommend that DHCF should stop procedural terminations for this population until DHCF can remediate the system's issues. Additionally, DHCF has declined to extend prior authorizations during the 30-day extension period for long-term care services and other essential services for this non-Magi group until the renewal is completed and approved, contrary to a request by DRDC and other advocacy groups. Without prior authorization, providers will not be paid for providing services during the extension period, and the provider may not be in a financial position to provide services without assurances that it will get paid. Extending prior authorizations are a necessary reasonable accommodation to prevent institutionalization, service terminations, and to maintain the health and safety of these beneficiaries. I would like to close by describing the issues a DRDC client faced when her Medicaid was terminated on July 31st. Michelle, and I'm using a pseudonym, is a 47-year-old woman living with an active stage 4 cancer diagnosis. The only reason Michelle knew that her Medicaid was terminated was because she had attempted to schedule doctor's appointments for her cancer treatment and was told by her doctor's office that she could not schedule an appointment because her Medicaid was no longer active. DRDC contacted Michelle's EPD waiver case manager and learned that her case manager had timely submitted Michelle's renewal in June. Neither Michelle nor her case manager have ever received a Medicaid termination notice from DHCF, nor could either of them tell by logging into District Direct that Michelle's Medicaid was inactive. Of note, Michelle had followed the instructions provided by DHCF to update her address in DC Direct. DRDC contacted DHCF to advocate for restoration of her Medicaid, and DHCF indicated that ESA reviewed and approved Michelle's eligibility on August 21st, almost a month after her benefits were terminated. This delay in ESA's review of her eligibility caused Michelle to be unable to access her cancer treatment for over 3 weeks. DHCF should take a proactive approach to ensuring accessibility in this process and improve renewal outcomes using all flexibilities authorized by CMS to prevent improper Medicaid and service termination. Thank you again for the opportunity to testify, and I'm happy to answer any questions.
Thank you, Ms. Niles, and I hope you stay on because I do have some follow-up questions. Ms. Smith?
Yes, can you hear me?
Yes, ma'am.
Thank you. Good morning, Council Member and Committee Chair Henderson and members of the Committee on Health. My name is Tamara Smith, and I'm the CEO of the DC Primary Care Association. Thank you for the opportunity to provide comments regarding the Medicaid and Alliance recertification and renewal process. This is a critical process for our health centers as well as Medicaid and Alliance beneficiaries, as you've heard. The community health centers in the District of Columbia serve 1 in 4 residents, almost 60% of the Medicaid beneficiaries. And in 2022, 10% of their patients were Alliance members. They're deeply committed to ensuring that every patient eligible for continued Medicaid or Alliance coverage retains that coverage. And we're willing partners to assist in this process. We have valued the partnership with the Department of Healthcare Finance. We know they share the goals to protect district residents from coverage loss if they remain eligible. We have been meeting frequently with DHCF to discuss a variety of issues regarding problems regarding recertification, eligibility, and sharing with them issues and recommendations that we think will limit both procedural terminations and disenrollment of eligible beneficiaries. We have ongoing concerns about adequate staffing, technical and operational challenges that may cause delays in continuing coverage. You've heard some of those, but we really appreciate the Department of Healthcare Finance's effort to be responsive, particularly to the problems we have raised with them as health centers and to proactively work with us to address them. We know that DHCF has been carefully monitoring coverage losses and has delayed procedural terminations for certain beneficiaries in order to conduct very specific outreach that many of the MCOs have talked about, particularly when anticipated terminations have exceeded expected thresholds. We appreciate the sharing of regular data. As providers, we're getting reports on individuals that are eligible for recertification. And so the communication process around who's eligible and having that both from the MCOs and from DHCF has been a good process. We know that DHCF has taken a number of measures to address the recertification, the renewal process. We particularly appreciate the fact that renewal for Medicaid eligibility for individuals with no income and no data returned on an ex parte basis, known as zero income strategy, is in effect, and that's been helpful. And again, we noted sharing the data and the resources and reports with both providers and MCOs to help us in assisting individuals in their recertification process. We have made a number of recommendations to the Department of Healthcare Finance. One in particular that our health centers feel is game-changing is the recommendation to designate FQHCs as qualified entities to make determinations of presumptive eligibility. Health centers currently have certified application counselors. They're trained by the Department of Health, the DC Health Benefit Exchange Authority, and they assist residents throughout the application and the renewal process. By allowing health centers to determine presumptive eligibility for patients, this will significantly improve the system's capacity for renewal and avoid inappropriate coverage loss. This coverage loss, as you've heard, can result in care interruption, inability to fill prescriptions, lack of access to needed specialists, et cetera. We believe the health centers are confident and capable of meeting all the requirements and performance standards to serve in this role as qualified entities to make determinations of presumptive eligibility. We have met with DHCF recently as last week, and we continue to urge them and you to move this initiative forward that enables health centers to determine eligibility. We know this capacity will lift significant burden on the systems and will enable additional resources to help with this recertification and this renewal process. And we believe that this it will enable reduction in the staff burden that really spends considerable amount of time submitting, tracking, querying, and communicating, looking for communication on beneficiary eligibility status. So we encourage both you to support this recommendation and the Department of Healthcare Finance to continue to work with us on this recommendation. Thank you for the opportunity to present this testimony. We will report back to you on how progress is made, and we look forward to continuing this collaboration work that's really essential. Thank you very much, and we're happy to answer questions.
Thank you. Thank you to all of you all for taking the time to testify and for the work that you do. I have some follow-up questions. I'm going to start with you, Ms. Smith, because it's fresh in my mind right now. Can you just remind me, how many FQHCs do we have in the district?
We have FQHCs, eight FQHCs, one lookalike. Mm-hmm.
Okay. And is the recommendation that FQHCs be allowed to make presumptive eligibility, is this something that all 8 want to opt into?
Yes, I think we certainly, they all have capacity, as I've said, to do this now, and they're assisting beneficiaries with this process. They have enrollment counselors, et cetera. Yeah, so they're interested. Certainly the larger ones, the Unity, Mary Center, Community of Hope, Whitman Walker, have the capacity and are interested. And we certainly feel strongly that they have the capacity and the capability of doing it, yes.
Okay. And to your knowledge, is this an administrative thing that healthcare finance can make the determination on? I'm assuming with some conversation they have to have with CMS.
Yeah, it is already a CMS allowed procedure.
Okay.
And DHCF has been receptive to it. And again, we spoke in detail with them last week about it. We've been talking about it for several weeks now, but we spoke in detail about it. So we actually really, and we talked to the health centers about it. So we really have a team of folks ready to work with DHCF to move this forward.
Okay, thank you. I'll follow up with Ms. Bird when she comes up. Ms. Niles and Mr. Patterson, you both raised the voices of clients and some very interesting and also troubling stories. Mr. Patterson, you talked about 45 days to process a renewal, and Ms. Niles, the client's paperwork was submitted on time, but there was a delay in terms of the ESA review, which then resulted in almost a month in terms of gap of care. Now, we were told that when someone's paperwork is submitted, there is a pause that is placed on terminations. Is that not something that you all are seeing with the clients for the organizations you work with?
So my understanding is DHCF has represented that there would be a pause on terminations so long as the paperwork was submitted timely. What I'm unclear about is why it didn't happen in Michelle's situation. and whether there's a mechanism in District Direct or their systems to put such a pause where, in the event that the case manager did submit the information. So hopefully that's something that DHCF can answer today.
Okay, Mr. Patterson?
I echo that as well. I think that oftentimes some of those safeguards that are put in place are not implemented every time on an individual level. There are mistakes, there are glitches. Paperwork can be submitted on time by the enrollee, by the someone helping them, but it may not get to the person on the other end who needs to receive it in order for those protections to kick in. We do see that a lot on an individual basis where someone will submit something. In this case, Medicaid, often with other benefits programs as well, they will submit it on time and that benefit will still be terminated. Often as advocates, we're left with the tools that we have, which are, filing hearing requests, doing the best follow-up we can with our contacts. Sometimes they can be responsive, other times it cannot be very responsive for us to try to raise these on an individual level. So we do see these problems as well.
Okay. That speaks to an issue in terms of technology, because I would think that if your system, if you're doing the process via computer, the whole point of us doing it that way was to sort of take out some of the human mistakes that could happen. Right. And so I would hope that our system, it's District Direct, so we spent a lot of money building out this program, would be able to determine, right, like all paperwork has been uploaded and therefore this person is marked complete pending review. And then, if this, then this, like those types of things. I'll follow up with healthcare finance on that. Ms. Schlossberg, I see you have your hand up. You wanted to comment.
Yeah, I think one of the issues that is unique with respect to individuals who are long-term care is that while DHCF has, for example, extended Medicaid eligibility for 30 days for those who were going to be terminated in June and July, I believe they may have done it in August as well. They have not extended prior authorizations for the services that those individuals are receiving, which means that while there's a technical extension of Medicaid, in fact, the providers are not paid, cannot be paid, and they can submit their claims, but those claims will deny because there is no active prior authorization. We have urged and asked DHCF to, at the same time that they're extending eligibility, extend prior authorizations. They said they weren't able to do that because that would require a manual process. But what then happens is that the providers can't see information in DC Care Connect. They're immediately blinded to that information, and they can't get paid. And but they're still responsible for the care of these individuals. Neither a home health agency, assisted living, or an adult day health can discharge those people. And in fact, in assisted living, they're living in the community. They have to continue to provide care to these individuals, and they're not getting, and they can't get paid.
Is there a retroactivity once a person is approved?
Once the person is approved, they can go back and bill. But again, the problem becomes cash flow. They have staff they have to pay. It becomes a financial burden and difficult for the providers.
Yeah. I was just talking to my staff here. It all comes back to prior authorization, which I feel like is taking years off our life to get that bill through in terms of the reforms and stuff that we are also working through with healthcare finance around long-term care in particular. Everybody else is easy. It's this one that is just the
Special
pain.
challenges.
Special challenge. That's a better. I said pain. You say special challenge. Great. I'll use that. Mr. Patterson.
I just wanted to add on to one thing that Ms. Schlossberg said, which is that another issue that we have seen in the long-term care population, people in the EPD waiver, also people just on regular Medicaid who receive personal care aid hours, is challenges that home health agencies have with staffing right now for a variety of reasons. So I think the point that Ms. Schlossberg just made, kind of goes along with that particular challenge of trying to make sure that these agencies have enough staff in the first place to provide the services that people have been approved for. So I do think that's a very key point.
Okay, we'll follow up with healthcare finance on some of these pieces. Mr. Patterson, in your testimony, you said, I have a list of recommendations, but they're too long. And so I'll provide it in my written testimony. Are there some things that you wanted to just raise for the good of the order now?
Yes, I mean, I think one piece that I wanted to address, and it sounds like some of the earlier witnesses testified to it, is, we are happy that there's this 90-day grace period that DHCF has extended to people who, if they get their recertifications done within 90 days of their termination, they will be their coverage will be established retroactive to their date of termination. We would just encourage DHCF and DHS and the MCOs to take as much advantage of that 90 days as possible. The notices that go out to enrollees are, depending on their eligibility group, usually prior termination notices. I don't know of any sort of orchestrated or specific efforts that are being done to reach out to people in the 90-day grace period. So I think to the extent that is not being utilized, or I would just like to perhaps hear more about how that 90-day grace period is being utilized from kind of a proactive outreach side of things.
Okay. I could definitely ask that as a follow-up as well, because it's one of the things I am also curious about, given how the MCO spoke about challenges around updated phone numbers, updated addresses, et cetera. If we know that we have 90 days to get these folks back, then what other means are we doing of outreach that might be different than before? Mr. Patterson, Ms. Niles, Ms. Smith, I think Ms. Smith, yours is a little bit different because you're dealing specifically with providers. And so, the work that they are doing, they're having direct contact with patients each and every day. But I'm curious, Mr. Patterson and Ms. Niles, Legal Aid Society and Disability Rights DC work with a variety of different residents. Are you all only seeing folks when they're having an issue, or are you also able to proactively reach out to the folks who are on your list about Medicaid renewals? I'm sort of thinking about it as in we're all in this together. And so maybe you have a fresh contact that we don't.
Yes, I can start. Yes, we do proactively do outreach to individuals with disabilities and other constituents about the Medicaid renewal process, including in-person outreach that we do in institutions in DC and community residential facilities and other community-based locations, where we have a handout where we give people information about the renewal and how to get assistance to complete their renewal. And we also have a newsletter where we provide information about the Medicaid renewal process, and also during intake. And particularly, we identified Michelle's situation because at intake, we ask individuals if they have Medicaid, of course, and if so, if they have started their renewal. And because we proactively asked that question, we identified Michelle's situation during intake because she actually contacted us about a different issue.
Our process is similar. We have our main office, but also some community offices. We put information in those community offices about all of the benefits programs that we provide assistance with. We also ask all of the applicants who come to legal aid, regardless of whether they're coming about a Medicaid issue or a public benefits issue in general, they may be coming in about a housing issue or a consumer issue. We ask them about their insurance status, if they're having any trouble with renewals, if they've had, a termination. So we do proactively reach out in those ways to anyone who's seeking assistance from legal aid.
Great. All right. Well, thank you all again so much for being here for your testimony. If we do not have your written testimony, this is fun. This is our first hearing since we've started this, but the council has a new hearing management system. And so as opposed to just emailing your written statements, if you go to the council website, dccouncil.gov/hearings, you can actually just upload it right there. Click our hearing and then upload your testimony. So if we don't have your written testimony, if you could do that, that would be fantastic. All right. Thank you guys so much. We're going to move to our government witnesses. We have two, but I'm going to split the panel. so that everybody doesn't have to be here for the whole situation. So I'm going to call up now Mila Kaufman, who's the Executive Director of the DC Health Benefit Exchange. For those who are in the public witnesses, you're going to be put back into essentially general viewing. And thank you again for being here.
Thank you.
Ms. Kaufman, good morning. Before we begin, I need to ask that you or anyone on your team who might speak today be sworn in. So I don't know if Herbie's going to join you at any point, but if it's only you, that's great. If you can raise your right hand and repeat after, well, answer the question after I say it, but do you swear or affirm under penalty of law that the testimony you're about to provide to the Council of the District of Columbia and this committee is the truth, the whole truth, and nothing but the truth?
Yes.
Great. You can begin your statement.
Thank you very much. And good morning, Chairwoman Henderson and members of the Committee on Health. My name is Mila Kaufman, and I'm the Executive Director of the DC Health Benefit Exchange Authority. We're responsible for DC HealthLink, the district's state-based online health insurance marketplace. We were one of 4 state-based marketplaces to open on time for business on October 1, 2013. We cover approximately 100,000 people with private health insurance, and that includes more than 80,000 covered through our small business marketplace, which serves more than 5,300 district small businesses and nonprofits, DC residents and their families, and Congress, for whom we were designated to be a source of coverage under the ACA. We're responsible for more than $670 million in annual premiums. And since opening, we have cut the uninsured rate by half. The district ranks number 2 in the United States for the lowest uninsured rate. We're here to support the Department of Healthcare Finance's Medicaid unwinding efforts. My main message to those losing Medicaid is simple. DC HealthLink is here, and we have health plans that meet every need and budget. Don't go uninsured. You need good health coverage for your health and financial security. Thanks to the American Rescue Plan and the Inflation Reduction Act, lower health insurance premiums are available for more residents on DC HealthLink. In 2023, we have 27 individual and family plans from CareFirst, Blue Cross Blue Shield, and Kaiser Permanente. This includes HMO and PPO options. These quality health insurance plans are available for as low as $11 a month. Just like Medicaid, you get free preventive care with all plans offered on DC HealthLink. And this includes annual physicals, vaccinations, birth control, cancer screenings, annual OBGYN exams, well baby and well child visits. If you enroll in a standard plan, you'll also have essential care without any deductibles. There are no deductibles for primary care specialists, including outpatient substance abuse and mental health and behavioral health providers, urgent care, and generic prescription medication. And our standard plans are now equity-based benefit design plans. As of this year, type 2 diabetes is covered at no cost to the patient. So this means no deductibles, no copayments, no coinsurance for physician visits, lab work, eye and foot exams, supplies, and insulin. Residents who no longer qualify for Medicaid do not have to wait for open enrollment. Our executive board acted quickly to clarify that the federal special enrollment period established for the federal exchange applies here in DC and runs through next July. This means anyone losing Medicaid or anyone who has lost Medicaid can enroll in coverage through us anytime through next July. Also, if your employer is covered through DC HealthLink and you're losing Medicaid, you can enroll in your employer's DC HealthLink group coverage. Our website, dchealthlink.com, has consumer decision support tools to help you to easily compare different plans and automatically determine if you can get lower premiums. And our website tells you very quickly what lower premiums you qualify for. We also have DC HealthLink assisters. These are navigators, trusted voices in the community who are trained to help you transition from Medicaid to private health insurance coverage through DC HealthLink. We're also actively reaching out to residents losing Medicaid. We're reaching out using email, texts, and phone calls. But if you're watching this hearing today and you're losing Medicaid, please don't wait. Go immediately to dchealthlink.com, or you can call our call center at 855-532-5465. It doesn't matter if you already lost Medicaid or if you're about to lose Medicaid. We can help you. Thank you, Chairwoman Henderson, for this opportunity to address both the committee and the public. I'm happy to answer any questions that you may have.
Thank you, Ms. Kaufman. You know, people might think it's a little strange to have the health benefit exchange here for a conversation about Medicaid renewals, but one of the things that DC has boasted for a very long time is the high number of individuals in the district who have health insurance coverage of some type.
And we'd like to keep it that way.
And exactly, we would like to keep it that way. And I think some of the heartburn that I have about as we go through this unwinding process is that we will no longer be number one in that regard, number two in that regard, top two, you know. And so I think it's important to talk about the ways in which we are handing off people, especially since we now have a pool of individuals who have either been terminated from Medicaid because they have been determined ineligible or terminated due to non-response. You talked about a little bit in your testimony that generally someone can only purchase health insurance on the exchange during the open enrollment periods that begin towards the end of a calendar year, you know, fall, winter-esque. But that there's a special enrollment period for someone who is losing Medicaid coverage during this process. How long does that special enrollment period last?
The special enrollment period is through next July. But let me just be clear, we don't want anyone losing Medicaid coverage to go uninsured and wait that long. They can enroll now. So if someone who lost their Medicaid enrolls today, they can actually select an effective date of September 1st, or they can select an effective date of October 1st for coverage through DC HealthLink. Now, if you come today and you just can't make a decision which health plan you want, that's fine. You have 60 days to make that decision once you select loss of Medicaid coverage as your special enrollment right. And just as a reminder, if you're just watching out there, you're not transitioning from Medicaid and you're wondering about our general open enrollment, it's November 1st through January 31st. But for anyone losing Medicaid, enroll now.
Okay, so each month, DC Healthcare Finance has been updating the dashboard. I'm looking at the dashboard now. I have it pulled up. You know, the first month there were 84 people who were terminated for ineligibility, and then it kind of grows from there. When we discussed this in May, the process was supposed to be that Health Benefit Exchange receives a list from Healthcare Finance of individuals who are losing their coverage in order for you all to do specific outreach to those individuals, a handoff, if you will. Has that been happening?
Yes, we get a list from Director Bird's team on a monthly basis for folks who are likely qualified for coverage through us. And our team emails, texts, and our assisters also call those folks on the list of likely residents likely qualified for DC HealthLink coverage.
So you're providing some very specific language there. What does it mean as someone who is likely qualified for coverage?
Someone whose income exceeds Medicaid eligibility threshold.
Okay.
They likely qualify for DC HealthLink coverage. And so we will or are contacting you or have contacted you if you're one of those people who lost Medicaid because your income is too high, for
Ineligibility.
example.
Okay, great. So what about those individuals who are losing coverage due to non-response? Are you getting those people in your reports?
Our focus are residents who likely qualify for
Okay.
DC HealthLink coverage.
All right. So then we're talking about in the last 3 months, a pool of about 1,800 people. I'm not sure if you have this data today, but how many have you all been able to successfully enroll from that population?
So our numbers are very low in terms of likely qualified for DC HealthLink coverage. Out of the pool of people we received, and my team looks at every single case to figure out if they should be on the list or not, like if a baby without social security numbers, that sort of thing.
Ineligible could also mean you got insurance through your employer. And so income wise, you're no longer eligible. So I'm just curious.
So out of the 19 people who are likely eligible for coverage through us, we've enrolled 4 into private coverage. So that's about 20% conversion rate. We are still reaching out to the remainder. We do not know if they have coverage through their employer or other type of coverage if they've moved out of state, for example, and we don't have their current information.
Okay, so just for clarification, the list, you've only received less than 20 names from Healthcare Finance?
No, we received a few hundred names. As we go through each person on the list, we're figuring out if they are likely eligible for our coverage. And we've seen some folks on the list who shouldn't be on the list. It's just a data report flaw issue that my team is working with Director Bird's team to clean up the data. But out of the ones that we've received who are likely eligible for our coverage, we've identified 19 people who are likely eligible.
Okay. I was expecting a higher number here. Especially given the number of people who are being terminated for ineligibility. Now, I know I wish I had more information in terms of like, if we are terminating someone for ineligibility, are we giving the reason why? Is it you moved, income, whatever the particulars are, so that can help understand a little bit better? Because I think for the public or those who may be watching, when we talk, they could go to the dashboard, see how many people have been terminated for ineligibility. And then for you to say, yes, of the list that we've received, though, only 20 of those we've determined to actually might qualify for our coverage. Then I'm left wondering what happened to the other, 1,700 or so people. But that's not necessarily in your wheelhouse per se.
I do want to note that the notices that DC Medicaid issues does include information about DC HealthLink. So even if a person isn't responding to provide their updated information to stay covered in Medicaid, they have information about DC HealthLink through that notice and can go on to DC HealthLink to see if they're still a resident, to see if they qualify for private coverage.
Okay. So the converted 4, is that from assisters who've reached out to folks or does that number also include people who just went to the website and selected lost Medicaid coverage as their special enrollment reasoning?
One of those went by themselves to the website and got themselves enrolled.
Okay.
The other 3, it was a combination of our assisters as well as our texting and email campaign.
Okay. One of the things I was thinking about in terms of sharing information or not. So you're receiving a monthly report from from healthcare finance, but you also have quite a bit of information yourself in terms of individuals who are on the exchange, either individually or through small group employer plans, et cetera.
Mhm.
Has there been any conversation with healthcare finance about comparing the data, if that makes sense? So let's say Boyd here shows up on your list as having insurance through one of your small benefit employer or small employer coverage plans. And yet healthcare finance also has him on the list for Medicaid too. Is this not a way for us to reconcile, like, oh, well, if he is over here, clearly with active coverage under an employer, then we know that he's either ineligible or choosing not to continue with Medicaid. Have those conversations happened?
We're constantly looking for ways to better use our data.
Okay.
Now, just because someone is enrolled through us, it doesn't mean that their Medicaid coverage could just automatically be terminated, right? I'm more concerned about what happens once a person loses Medicaid and we're not really sure what happened to that person's new coverage. Is the person covered through us? Are they covered through another mechanism? And so one of the things that we're working on is adding a question to our text campaign to ask if that person who we're texting has other coverage. And so we're going to add that as an additional mechanism to get more information about where people are going. But also, once we're further into the termination of Medicaid process, then we can do a better job looking at our data, combing through to see if that person who lost Medicaid ended up in our small group marketplace.
Yeah.
And we're constantly looking at who's enrolling on the individual side and looking at who's selecting loss of Medicaid as their special enrollment period. So we have that data coming in, and in the near future, we'll be looking at the shop side to see if we can match those data points.
Okay. I mean, I think that there's likely some overlap here, especially when I think about the Healthcare for Childcare program. A lot of those individuals are now getting health insurance through their employer when before either they didn't have any insurance whatsoever, or they were getting their insurance through Medicaid. So there's probably some duplication here, but I think one of my frustrations is that everybody is now just adding this question about if you are receiving insurance from other places, because I feel like that is a missing piece here that could help us refine all of our efforts. Because right now, let's say I get a text message from you guys talking about it's time to renew. You would likely mark me as a non-response because I look at it and I'm like, well, I already have insurance. So like there's no other action for me to take because no other action is being prompted of me if I do have insurance coverage some other way. So I'm encouraged to hear that you guys are going to add that in your campaign. But
you mentioned healthcare for childcare. So for that population, we have worked very closely with Director Bird's team to essentially anyone who is on our list for healthcare for childcare as eligible, but who is currently covered in Medicaid, their redetermination, their renewal is being shifted to the very last phase. And that's to help avoid confusion and just, more turnover in coverage. So those folks, we get a monthly list from OSSI and the Medicaid staff looks at who is actually in Medicaid and then shifts their redeterminations, their renewability till the last phase, till next spring.
interesting. Okay.
So it's a little, so we know what's happening with that population to your point. That population is staying covered with Medicaid. And then anyone new we find through our healthcare for childcare efforts who is eligible for Medicaid, we obviously get them enrolled in Medicaid.
Okay. I'm over my time. Apologies. We have been joined by Councilmember Gray. Councilmember Gray, if you're still with us, if you have some questions for Ms. Kaufman.
Thank you very much, Madam Chair. I appreciate the efforts that you're making. today. So I'm very, very excited about especially what's been done with the efforts that have been done with them with these folks. So otherwise, that's all. I don't want to carry this longer than it needs to be.
All right. Thank you, Councilmember Gray. Thank you, Ms. Kaufman. We are going to take like a real quick 5-minute break, and then we are going to bring Interim Director of Healthcare Finance, Melissa Bird, up to the table. Ms. Kaufman, thank you so much again for being here and for the work that you all are doing.
Thank you.
Thank you. 5-minute break. Okay, and we are back. Hello to the team from Healthcare Finance. So we'll call our final government witnesses, Melissa Bird, who's the interim director of the Department of Healthcare Finance, and Eugene Sims, who is the interim state Medicaid director. Great. So before we begin, I will ask that you all, you or anyone else who might speak. So I don't know if some of your comrades on the side here might also join you at the table. If you raise your right hand, do you swear or affirm under penalty of law that the testimony you're about to provide to the Council of the District of Columbia in this committee is the truth, the whole truth, and nothing but the truth?
I do.
I do.
Great. Before you begin your opening statement, I just want to say for the record, I did speak with Director Kaufman during our break, and I requested some additional information about their data numbers around who they're receiving from you all and how many folks that they are connecting with to enroll. My understanding is she expressed that there might be some sort of data glitch, that they are in contact with you all and you're working through that process, but that also there's reporting up to CMS about this, and that some other jurisdictions are having some numbers that folks may not expect given how many people we're talking about, but that this is something that everyone across the country is sort of working through. So I want to make sure that I say that for the record, but I don't know who's doing testimony today.
I will.
Great, Ms. Bird, please
Thank you so much. Good morning. My name is Melissa Bird. I'm interim director for the Department of Healthcare Finance. Thank you, Chairperson Henderson and the committee for the opportunity to speak on Medicaid renewals, which, as you know, is the restart of Medicaid eligibility recertifications for the first time in 3 years. You can turn off and tell you. As you know, we just issued our second Medicaid renewal report at the end of August, which captures our experience to date. I am happy to report that DC leads in some areas when it comes to the Medicaid renewal process, and looking nationally, we are 8th highest overall in terms of our renewal rates. That's 8th out of 41 states reported by the Kaiser Family Foundation. And we have the 6th highest passive renewal rate also out of 41 states, not all 55 Medicaid programs. Of course, while I'm glad that we're doing well, comparatively speaking, there are areas where we have some room for improvement, and you've heard some concerns expressed earlier today. I'll highlight, and some of the things front of mind that we're working on kind of as we speak is correcting the ex parte for children, specifically something called ex parte on the individual level versus the household. We've raised before in other public venues our concerns about certain populations of our beneficiaries who we are seeing fewer response, and typically that falls into what we call our non-Magi group, specifically our QMB only and our low-income, aged, blind, and disabled. And looking forward, as we kind of continue on in the renewal process, obviously as more individuals join the renewal process, if you will, and we increase our numbers month over month, I do have concerns, and we are looking, monitoring closely the case processing timeframe. I think we've heard some of those concerns this morning, and that's something that as we continue to move forward, July and August were our largest numbers of renewals at about 30,000 and 28,000 respectively for July and August. We'll have a couple more high number months, October, November, as we close out the calendar year. So that's something that we'll be paying a special attention to. I do think efforts underway, some of the additional flexibilities we've requested from CMS, our federal regulator, will assist us in that, as well as fixing the ex parte issue I spoke of earlier, simply because that means we anticipate or hope that our passive renewal rate for children will increase, which means there will be fewer cases to process and hopefully streamline some of the pressure on our caseworkers. And so with that, I'm happy to take any questions that you may have.
That was very short. For those who haven't watched our hearings before, when Director Turnage is here, he's usually giving me a hard time about the time limit. So nonetheless, it's always good for us to just get into some questions. And I want to say off the top, I appreciate, number one, the communicativeness between you all and your team with the committee. throughout the summer, as we've discussed what's been happening, what's been occurring. But also, we came up with this idea to try to help enlist advisory neighborhood commissioners in that effort. And we appreciate you guys doing an evening webinar and taking some important questions for those folks who are closer to residents, who can probably help out some neighbors to get them connected. I do have some questions. I want to start with talking a little bit about the case processing timeline and framework. As we heard from the public witnesses, they have some issues in terms of individuals taking up to 45 days, et cetera. And I know that the process is different for those who are in long-term care or who have EPD waivers, et cetera, versus someone who might be in their 30s and no dependents. And so what is the timelines looking like separated out? So if you are, let's say, young and no dependent, and you fill out the paperwork in time and your case isn't complicated, how long is that taking versus someone who does also have to have the physical evaluation to determine whether or not you still need that level of care?
Sure. And I'll start by saying I'm not sure if we have at hand the timeliness right now on case processing. I know on the CMS reported data, and I'll have to confirm if it's just MAGI or MAGI and non-MAGI, we are seeing a higher rate exceeding that 45-day timeframe. We do technically have up to 45 days to process a renewal. The thing that I think is important here, and something that we're looking into right now because of an uptick of beneficiary concerns we have heard really just over the past week, is the case that was brought up by Ms. Niles earlier. Someone, clearly paying attention to all the outreach, responding timely, but then having their eligibility not recertified timely and losing their eligibility at that time, which is not our intent. Our intent is that if you're turning the paperwork in time, we're going to extend you. What we think might be the cause of that is depending on the day of the month we're in that you submit your renewal application. So for us to extend, we do need like a 24 or 48 hour time period from a systems perspective. You spoke of systems earlier.
Right.
And we have seen, I know at least for the end of July, like we saw a fairly significant number of renewals come in like July 31st.
Oh, I see.
And so in a case like that, it's probably going to take us a month before we can extend that person's eligibility. So that's something that I don't know if there's another fix for it, so we can have that continuous coverage. But that's something that we're starting to look into because as I mentioned, it really has been for us in the past week, I've received more calls or inquiries about a lapse in coverage than I have seen since we started in April. So that's something that we are actively working on and have become aware of. But again, the intent is, and our course of action has been to, if we have the paperwork in, we're extending you until the case is processed, at which time you'll either be recertified for your 12 months or will lose coverage.
Okay. So let's talk a little bit about that from a staffing perspective. How many people are working on reviewing documentation and then making determinations?
I can't tell you staff numbers. That mostly goes to the Department of Human Services, to the Economic Security Administration. What I can tell you is that we work closely with them through Eugene in his day job as policy director and oversees our division of eligibility policy. To help support ESA, we did bring on, I think it's 12 staff earlier this year to help with some efficiencies. So making sure that we are scanning paperwork that comes in timely. I'll step back for a moment. I think anytime we're receiving a paper application, there's always going to be challenges because there are more steps to getting it into the system. So with that in mind, we brought on additional staff to work with ESA for that kind of whole, getting the mail in, scanning it, getting it in the system. I also know, and Eugene can speak more to this, that ESA has changed the scope of how their staff work, where they can work on, I think, more cases than just what they might have originally been assigned to. So maybe they were only working SNAP cases. Now it's expanded to work medical assistance cases. So that increases their capacity as well.
Okay. So I don't have all the agencies here that are needed in some way. I mean, anecdotally, are they let me back up. Anecdotally, we know that Department of Human Services has had some challenges and issues in terms of hiring and retaining staff. would they have made that aware to you all that they need additional support in these upcoming months?
We've had ongoing communications with DHS. I mean, when we first thought renewals might restart a couple years ago, and we've talked about, staffing capacity. One of the things, another thing that we did is we, detailed what they call their Medicaid branch over to the Department of Healthcare Finance effective last year. Those are the group that works on non-Magi applications. And so having them in-house really allows us the opportunity to bring in our policy group, our long-term care group, and the systems group from DCAS working all together on those applications because they are more complicated and they do kind of touch on all those groups. So I think that's supportive. I think the other thing to bear in mind of the challenges, and I think you referenced this earlier, maybe an earlier witness, is that we do have the new system. And for the first time, we're doing renewals in it. So there is going to be, that more of a focus for us on training. And are we helping the caseworkers understand, what's the new process? On top of that, as we are trying to bring in these flexibilities that we want to see to make renewals even more efficient and possible, every time or almost every time we add a new flexibility, that has the potential to change the caseworker process,
Right.
which means you have to go back for training. So I think it's really from my side and what we can do to support our colleagues over at ESA is how can we support them in being as efficient as possible, raising issues that we see and making sure our team's available as much as possible.
Okay. I mean, I'm going to follow up with DHS because I think there's this question of, yes, you have 45 days to process, but if you're not hitting the 45-day number, then I have to ask what is going on in terms of the processing piece. Now, it could be for any number of reasons, flexibilities, increase in this, that, and the third, but if we have designed our renewal process to ramp up, right? And so then my question is like, what are we going to do for September, October, November? If they don't have enough people, what are we doing for September, October, November? And I appreciate that they've detailed their Medicaid folks over to you guys, but if you're not doing the bulk of the processing piece for Magi, which ones do you?
We take on the non-Magi,
Right,
so they
so-
have the Magi, which is the bulk, yes.
Right. So if they're taking on the bulk in terms of the Magi, but they don't have the staffing capacity, and I'm kind of guessing that they don't because I know what our application processing is for SNAP. We're like the lowest in the country. So like, then we got to focus some attention over there. And so then I need to, talk to my colleague, Councilmember White, who has DHS in his portfolio to figure out like, what are the additional supports that are necessary and needed to make sure that the whole machine is sort of moving in the right direction there. Let's talk a little bit about what some of the other public witnesses raised around specifically with regards to long-term care. And so I know that a couple of months ago, we had some delays in terms of individuals who needed the fiscal evaluation. I think we cleared the backlog, yes?
So I think you're referring to our level care assessments
Yes.
conducted by Liberty. Yes. So when we resumed in-person assessments last October or November, that introduction or reintroduction of the in-person assessments caused some pressure on our ability or Liberty's ability to timely get those level of care assessments completed. Since then, I believe they've doubled or tripled their staff. Catherine can give me the exact number, and we are back down to a 5-day time frame from request to completing the assessment. So that I don't have any current concerns about making sure that we have timely level of care assessments for folks in the renewal process.
Okay, so once we have the level of care assessment and the assessment in terms of income eligibility, where's the cog in the system in terms of continuing prior authorization for the care?
I think there are a couple of things. First, on the prior authorization issue, I'll say a couple of things. I know there was a lot of discussion earlier about the impact to providers, but we aren't hearing directly from providers about the concerns of the approach that we've taken with extending the non-Magi eligibility and the approach that we're doing with the prior authorizations that Catherine can speak to in more detail. I will also say that we would not have taken the step to extend the eligibility by 30 days if it meant people weren't going to get services, because in effect, then what's the eligibility for?
Right.
So our intent and what we have done with those extensions is that individuals continue to receive their services. Most of the providers still have access to the person-centered service plans. I think there's just one group, the assisted living residences, that might lose that access, but in talking to Catherine earlier, that is something that if you know someone might be losing their eligibility by the end of the month, they could print that plan out just to be prepared and still have access to it. And then the final thing I'll say to the whole prior authorization issue is that, as we're trying to make changes and pivot and make the process as effective as possible, just overall in terms of renewals, we always have to think about the short and long-term impact, right? So the short-term impact is that we maintain coverage. If we did something different with our prior authorizations and in the short term extended them for the 30 days, that has a like down the road impact of you kind of have to like then unwind it to then get people back on their 12-year plan with a 12-month plan, 12-month plan along with the prior authorization. So it's this kind of thing of how do we, first and foremost, maintain access to coverage and services for the beneficiary. And then in the back end, how do we, do what we need to do to support our providers with the least disruption, short and long term. And that's really what guides some of our decisions on that front.
I hear you on that front, but I also think about the disruption perhaps to a patient if a service provider doesn't extend grace, right? And is like, well, yeah, you have Medicaid coverage, but I don't have prior authorization to continue this forward. So therefore we're going to have to, I don't know, move you out or do something different, or
I appreciate that.
you need to put a credit card down, like whatever that might be. And I can't pretend like that's not something that could happen.
Oh, certainly. A couple safeguards in place. First, I will say, I think we've heard of maybe 1 or 2 cases of such a thing.
Okay.
Second, providers have to give a 30-day notice before discharging a patient. And so that is the piece that if they're not doing that as a provider, then we have recourse. We can make, reach out to the Department of Health as the regulating entity and talk about how the transition of care or continuity of care is not working in that case. Catherine, I'm welcoming you to add anything that I may have missed.
Sorry, I can't see the red light. My name is Catherine Rogers. I'm the Director of Long-Term Care for DHCF. And I would just echo everything that Melissa said. Both Medicaid and DC health requirements have notice requirements for providers to discharge from all of our licensed, all of our Medicaid long-term care providers. We've also been having this conversation with our long-term care providers since March before we resumed renewals so that they were clear on their expectations about discharge and about monitoring eligibility so that they can be a part of that conversation with the beneficiary and with the case manager.
I could just see a situation though, again, worst case scenario, because we know from, our MCOs, some of the providers know when so-and-so is going to be due. And so I don't want that to be used against someone in terms of like, well, this person was kind of a pain anyway, so we may not explain it. And then on the 30-day process, when we know you still haven't submitted your paperwork yet, we're going to go ahead and process your discharge paper or notice of discharge before it even gets to that point. Again, worst case scenario. And I don't believe that any of our providers are doing that, but I just want to make sure that we're on the up and up. I'm way over my time. Councilmember Gray, do you have some questions for this panel of witnesses?
Madam Chair, thank you.
All right. Thank you, Councilmember Gray. All right. Let us continue on. Okay. So in addition to Medicaid renewals, we've also been renewing our Alliance folks at the same time. We talked about what was going on with Alliance because we started them earlier. How has the process and also lessons that we learned from dealing with our Alliance renewal population, how has the process compared for Medicaid versus Alliance in your opinion? Are we seeing more or fewer non-responses? Is the drop in enrollment similar to the termination rate for Alliance?
Sure. I'll start with just a little context of the differences or similarities between the Alliance renewals and the Medicaid renewals. First, with the Alliance renewals last year, individuals because of being in the Alliance population and going through the renewal process for the first time in our new system, there was no passive renewal option. So everyone had to submit some kind of renewal form. So that's one significant difference. Second, when we started the Alliance renewals, there were new policy changes that impacted the renewal process. And there are not the same kind of policy changes for the Medicaid renewal process this time. And what I'm speaking of specifically is we eliminated the 6-month recertification and we eliminated the face-to-face in-person. And so I raise those just again, it shows a little bit of the differences between the two renewal processes that we're going through. Generally speaking, on what we are seeing overall, the Alliance renewal rate is looking lower than the overall Medicaid renewal rate. But when you compare Alliance to our non-Magi population, so a subset of our Medicaid, we are seeing more similarities in those renewal rates. So that's kind of where we are. On lessons learned on the renewal process with the Alliance group last year, one of the biggest lessons learned for myself was when we first started hearing of issues with Alliance recertification, we heard from providers. And, initially that wasn't our first place to go for outreach and discussion. But we learned very quickly, and it's kind of like an obvious, like, yes, I go to my pharmacy to get my my prescription. That probably more routine than I may even go see my primary care provider. So when we started the outreach or talking about how we do outreach for Medicaid renewals, there was a more deeper level of engagement with the provider community. We had initial meetings with the pharmacies. That was really just the biggest takeaway for me is we need to make sure the pharmacies are aware of what's being requested by our beneficiaries and other provider groups from, Catherine's group has been talking with the long-term care providers routinely. And then bringing in, the FQHCs, the medical society, really just trying to get the word out as much, and the behavioral health providers, because that's another group that you may be seeing more frequently than other providers. So I'd say that's the largest takeaway. Other is just expanding how we do outreach to the beneficiaries. So we've added text messaging, the automated calls. You've seen a lot of public media, flyers, a communications toolkit, really trying to have a single message so that if our stakeholders are using that message, we're amplifying it and getting the word out.
Great. And I remember distinctly we had an issue with processing paper applications in Alliance. Please tell me we don't have that issue with Medicaid in terms of boxes going unchecked for a period of time.
Not to my knowledge at this point.
Okay.
We have I spoke earlier about the staff that we brought on board to support ESA and the scanning of documents.
Right.
So there is not only are we tracking, mail, we have applications coming in, scanning, getting them in the system and registered so we can maintain that coverage.
Okay. And also on the mail front, we talked about this a month or so ago, but have we seen a change in the amount of return mail we are receiving?
So I don't know if I can say a change from pre-PHE to now. I see Eugene shaking his head, so he may say differently. We have some preliminary data on collecting return mail. The interesting thing on the return mail for the pieces, and this again is all preliminary, there's a decent amount, I'll have to look at my notes for the percentages of return mail coming back from folks who are passively renewed. And so the good thing about that, if you will, is so we might be getting return mail, but we're still reaching the person. And really, that's the most important piece of it. But Eugene, would you like to add anything?
Yeah, just a little bit to add. The bulk of the return mail we're seeing comes back with no forwarding address. We were worried that, we're sending mail and someone's moved and they've updated a forwarding address. I think the vast majority, maybe over 80%, comes back with no forwarding address, which means there just may be an error in how the beneficiary entered their address in our system. I think we're seeing 1% come back with an out-of-state forwarding address. That is a special piece of mail when it comes back because it creates an obligation on the caseworkers have to then reach out to that beneficiary because they may no longer be eligible for DC Medicaid because they live in Maryland or Virginia. And I think about 17% or so, 16% comes back with a in-state forwarding address. So we're partnering with DHS, some of those same staff that Melissa mentioned, handling return mail, also, scanning in paper materials. We're working with DHS to make sure that when something comes back with a return address, there's a process in place to then resend that renewal to that updated address so that it can go to the beneficiary, they can take action to renew their benefits.
Okay. And the staff that you brought on, the 12 for ESA, are those temp or full-time?
Those are contract staff. They've
Okay.
been with us since April of this year. They will be with DHS through September of next year.
Okay. Okay. One of the things I thought was so interesting in the latest report that you sent over is the geographic breakout of renewals or non-responses, et cetera. And people wouldn't think this, but across all 8 wards, it's generally everybody in the 60 percentile range. Are we comfortable with this?
Are we comfortable? I mean, I don't know that I'm comfortable with it. I do. I think much as you, it is an interesting point, right? It is interesting to us that almost across the board on so many different measures, there is a pretty much consistency, whether you're looking at percentage across ward who's renewing, it's male, it's female, it's someone in managed care, it's someone in fee for service. It is interesting is the best word I have for it. And I think until we started in April, but we really have May, June, July, and we're just getting August data in. So for the Magi group, we have about 4 months. And for the non-Magi, we're really at about 2 months. So I'm curious as we get more data and the data team at the agency continues to look into it to see if we see, something that kind of explains that. But, on a positive note, it could say that, that's just kind of how the district is falling through or kind of coming through the renewal process.
Yeah.
And maybe that's where we're supposed to be. But I still think we're too early on to say that, that's the way it's supposed to be.
Okay. You mentioned that one of the flexibilities we're sort of taking CMS up on is around continuous coverage for children. No,
That's
I'm
a nice way
projecting.
to put it.
I'm projecting what we hope, but I guess can you explain a little bit in detail what's happening with the children population? How long are we going to continue that extension for? And what additional follow-up is happening to make sure that it's not a ghost continuous, but like we are actually then connecting with the families?
Sure. So the issue that was recently identified by CMS was that there is, and where they clarified their guidance, I think 2 weeks ago now, is the requirement for passive renewal, or you hear it more commonly on the federal side as ex parte, but they're the same thing, is that it must be completed. And I'll step back to it. And for folks who may not be familiar, ex parte or passive renewal just means that we have the ability to ping enough different electronic systems and confirm someone's eligibility and renew them without the individual having to do anything. And so what the clarifying guidance is that the passive renewal review has to be done on the individual basis. So if I have a family, a mom and 2 kids in the household, if one person of that household pings back with an issue so they can't be passively renewed, right now we are not passively renewing that whole household. But what we should be doing is not passively renewing the one person and then assuming the other 2 still passive renew, they should passive renew. So that's the problem. We anticipate this is the largest area of problem this will be with children because their income eligibility levels are higher than parents. They're at 324% of the poverty level. Parents are around 214 or 15 or 16, 216, thank you, of the poverty level. So that's where we are concerned, where we might be missing kids that we could passively renew and ensure their coverage. So I think that came out on the 29th or 30th of August. The great thing is we were able to pause those procedural terminations starting with the August group. I anticipate we'll go back for the first couple months and reinstate folks. What our focus is on right now is how we resolve that issue and make the systemic fix, which is underway right now. And then once we have that, then we will implement the individual passive renewal process as is. Until then, we will not terminate children for a a procedural termination such as that.
Okay, but I guess the question I have is, let's say, for instance, you do have a situation where it's an adult and 2 kids. We are passively renewing the children. What if upon further examination, we determine that the parent is actually ineligible? What happens?
Well, if we find out the parent can be ineligible and the children still be eligible. And so if the case of the mom and the two kids, the kids are passively renewed, let's say, because the mom's income is at $250. So the kids are still eligible, they're passively renewed, their coverage remains as is. For the mother, assuming we confirm, well, if she's non-passive, then she'll receive an actual renewal application.
Right.
A renewal to complete. And if at that time, they present information that confirms that, we didn't have the right income amount for some reason, or maybe we couldn't ping an income and they provide, verification of proof. My income is only 210% of FPL or whatever amount for that month, then they would be redetermined eligible. And if they are truly over income, or if there's another eligibility requirement that's not met, then that mother would be terminated from the program, but her children remain.
Okay. One of the biggest requests or feedback that I've gotten from people, whether it be providers, MCOs, et cetera, of like, what's the number one thing that can help you improve in this process? And they all say more real-time data. Can we, I think we update the dashboard once a month now.
Yes.
And I know that might be aligned to our reporting to CMS, but might there be an opportunity for us to go to, let's not get crazy here, twice a month?
I will certainly look into it. I don't know what it is in terms of the lift for staff, but it is what you're hearing though from stakeholders that it's the dashboard data, or is it other data that they are looking for?
I think it's, dashboard data is great for us.
Yes.
To kind of know what's going on, but I think for them, it's other data around, they have a list of individuals who, let's take the MCOs for instance, they have a list of individuals for whom is signed up and on their list. To only have information once a month about whether or not someone has actually taken action, it doesn't help in terms of refining their efforts of outreach, right? Like if on, they got the list from you on August 11th, the person then actually renewed on the 15th, they don't actually need to reach out to this person for the rest of the month, but they wouldn't know that until deep into September.
Yep. I think, and I'll have to turn to April or at least on this one. I thought we had an overnight feed updated to the managed care organizations, but one of the challenges or issues that we'll have with that data sharing is when we, one of the great things or something that I'm proud of so far, when we've had to make changes and extend eligibility with, before the last day of the month, that's great. And we can effectuate that for, purposes of the beneficiary maintaining coverage, but then getting that updated data and that decision, then communicating beyond, like it goes into our Medicaid management information system and then over to the MCOs. I think that's probably where the challenges really lie, is how then do we make sure the changes that we're having to make quickly in response to whatever issue is as effectively shared down the line, if you will. April, I don't know if you have anything to add.
If you could just introduce yourself for the record.
Yes. Hi there, April Grady. I'm the Director of our Data Analytics and Research Administration at DHCF. I just want to highlight that whatever is in our Medicaid management information system right now is updated at a minimum weekly and is available to MCOs and certain other providers. Providers can also get daily updates on demand for individual beneficiaries by querying the web portal. So we can definitely follow up to ensure that there's an understanding of how frequently things are being updated. As Melissa said, MMIS is only as good as the last update. So if there's a delay between transmitting something between the eligibility system and MMIS, that's where we can get a little bit of a delay. But at this point, weekly refreshes should be available at a minimum.
And then I'll say one other thing we just kicked off last month, I think it is a new report through our Health Information Exchange, CRISP DC. Right now, it's only available to our FQHCs, but it is a report of beneficiaries. I think it's a 90-day in advance of their total panel of individuals that will be due for renewal so that they can conduct outreach. Our intent is to expand that to other provider groups in the coming months. We're just not there yet, but that's one avenue where we have been trying to make data more available to the folks that we work with. Providers have access to that data now through our, there's a provider portal, but it is not, I would say it's not as easily captured as it is through the new reporting tool through the HIE.
Okay. And some of the other flexibilities, so speaking of MCOs,
Some of them brought up the optional CMS flexibility to allow MCOs to assist individuals with their renewal process. Does healthcare finance plan to implement that?
Yes, we actually submitted our request for that flexibility and a few others like the presumptive eligibility for the FQHCs.
Oh, okay. That was my
Something-
next question. Great.
Okay, great. I think the 100% FPL, there's another flexibility there, but it's about 4 or 5 flexibilities we submitted to CMS last week, I believe.
Okay. Do you mind following up with the committee just to provide us with a list of
Sure. We'll share the
flexibilities you
letter
all
with you.
requested? All right. So one of the things that I have been trying to communicate to people as they look at the dashboard is a reminder that there is this 90-day window, grace period, if you will, after a renewal deadline where someone does have an opportunity to submit their paperwork and it'd be retro back. How many people are you all seeing responding in that 90-day period at this point?
Sure. I think the amount is about a quarter, but I'm going to turn to April to confirm. Okay. Yes, about a quarter, about 25% of folks
Okay.
are coming in during that grace period. And you will see, and this is something that's consistent too so far for the past 3 months, the response rate has been fairly consistent from like the 3 to 4 week prior to the termination date all the way to that like week of. We're seeing similar kind of increases week over week that we've seen, month over month. So there is a little bit of consistency there, and then seeing people come back in during the
For some
grace
people,
period.
we're toxic. We like to wait till a deadline and like,
It's
do things. Or then
people
after
are just busy and they're trying
people
to.
are busy and then they realize, oh shoot, like,
Mhm.
oh no, you're really going to cut me off. So let me, get that together. Should we anticipate or be working, like, I guess one of the things that's sort of hard to know is 25% a good number? Especially since we don't really have the information around like how many of these folks it's like, no, I already have something. So let's talk a little bit about that. Are we late in the process, not late in the process, but is there a mechanism whereby maybe in district director or otherwise in the outreach calls and efforts where there can be an option to say, I have coverage through something else, or I have moved, so that we have a better understanding of like what the real universe looks like?
Sure. So the way we have approached this is very similar to what Director Kaufman talked about earlier, and that we are implementing, I think it's this month, with our text messaging, and then eventually with our automated calls. We are adding in that response of, I'm not going to renew.
Okay.
And I think that's the best avenue we have for collecting that data. And then we'll get monthly reports that will provide that level of detail for us. And then we'll start to get a sense of, the number of folks who are dropping, maybe that's in the correct ballpark or not. Yes, please.
And part of our standard process, and this has always been available, is that we ask beneficiaries if they're moving out of state or they were experiencing other change, we call it change of circumstance, that they report that to us. They can do that via District Direct, or they can decline their Medicaid enrollment via a separate form. That process is always there. We probably see less people take advantage of that opportunity. So the alternative means of collecting that response, so you intend to renew, et cetera, will be necessary. But there is already a process in place if someone wants to affirmatively reach out to us, report a change of circumstance, or simply request disenrollment from their Medicaid coverage.
Okay. So of the residents who have lost coverage, I think the thing that gives me heartburn is about 90% have been due. 90% of the procedural terminations have been due to non-response. And I hear everything that everybody is doing on that, right? We're trying to get people text message, phone calls, working with FQHCs, doing the other types of pieces. So what's not working here? What do we plan to do differently in the next couple of months to get that number lower?
First, I can't say unequivocally that means something's not working,
Okay.
but doesn't mean that we're not going to investigate, right? I think what is unique in our kind of working hypothesis on our high procedural termination rate is because of our high eligibility rates or levels in the district. So if someone's going to renew, the likelihood that they renew and are eligible is fairly high. Now, in another state, you may have a lower likelihood of being successful your renewal because their eligibility levels are lower. So our options are most likely you're not responding, or you're going to be eligible and you're going to renew. And you called out that data earlier, the people who've been determined ineligible is a really small number, right? And it bumped up for July, August, which we anticipated because we had our PHE group in there, which are folks that we were pretty certain we already had some indication that they weren't going to be eligible. So I would just say in terms of like throughout the renewal process, I'm not thinking or expecting that procedural termination rate to drastically drop. That's the working hypothesis right now. Where can we do better though? What the data is showing us in some key groups of where we see higher numbers of folks not responding. It really is, for me, it falls into two groups, not for me, the data shows it falls into two groups. One is what we call our QMB only group of folks. And these are folks who receive Medicare. They receive Medicaid, but our role for them is only paying their Medicare premiums and cost sharing, so any copays. So their relationship to us is pretty non-existent. And so we don't know if folks aren't responding to what we're sending because they're like, who's Medicaid? I don't have anything to do with Medicaid. I get Medicare. And so that's one group that we are particularly concerned about and thinking about how we can change how we reach out to those folks. We've had just a very initial conversation with our federal counterparts in the duals office, because I'm thinking it might be more beneficial to have the Medicare side reach out to folks and say, you're going to get something from Medicaid and you need to respond because it pays for your Medicare. The positive thing on that side is folks have Medicare coverage and for at least, a month or so afterwards. The other group where we are seeing higher non-response rates than I'm comfortable with is on our, what we call our low income or our aged, blind, and disabled population at 100% or less. These are folks that really, we believe like they're likely really still eligible and it is a no response issue. We're thinking about at this point of how can we better do outreach by partnering with some of our sister agencies in a more targeted fashion, like the Department of Aging and Community Living or things like that. Potentially, do we go on site to certain places and reach out to folks? So that's one area that we're trying to figure out. There may be a flexibility, one of the CMS flexibilities that may help us out with that. I'm just not sure yet, but that's really, it's kind of those areas that kind of cause the most concern and figure out how do we better reach those folks.
I would definitely suggest partnering where you can with Department of Aging. We have senior wellness centers around the city. We have seniors who go religiously every week. And with some of their programming, whether it be the meals program or lunch, is a perfect opportunity. If you send it out in the newsletter before you come or have staff go to say, bring X, and we will help you get through the renewal process. And most, if not all of our senior wellness centers, I think all, because I've been to all of them, have computer labs, right? So it's not as though you all would have to bring some massive amount of equipment, but rather it's just helping someone to say, all right, Ms. Bird, it's time to go through the process. Did you bring the paperwork that's necessary? And then having someone who can just sit there and walk you through it yourself. That might be an area,
yes,
where we could do some more targeted outreach and get to, specific populations of folks.
We did do initial training and outreach with our senior wellness centers or senior centers, and folks should be able to go there and get assistance. But I think it might be the point in time where we kind of go back in and double check on those things.
Yeah, that would be really great. Give me just a second. Have you all been tracking the call wait times to your call center for folks who are calling with concerns?
We do on what we call our tier 1 call center through the DCAS system. So that is something that we do track and it is reported to CMS as well. So you will see, I can't remember the exact, I think we're at 5 minutes or less. I'll have to pull it up, but our call center wait time has remained essentially the same for the first couple months of reporting to CMS. So that would be March, April, and May.
At the beginning of this process, when we first started talking about renewals during budget, during oversight, our hearing in May, you all had to submit a plan to CMS to say, this is what we plan to do. In your best estimation, have you all been executing the plan that you had laid out to CMS?
Yes, we have. I think the most recent kind of change up is this new ex parte on the individual level issue, but the flexibilities that we've requested back in early part of this year, we've largely implemented. We had mitigation strategies like most states just for starting or kicking off the renewal process and agreement with CMS on which things we needed to do on that front. We've been doing that as well. So overall, I think we've executed pretty much according to plan.
Okay. This is one of those situations where there's a lot that's sort of outside of the government control. We can plan, we can call you 11 times, we can do all of these different things, but one of the things we can't do outside of passive renewal is sit down for someone to respond to the notice. And I think that that is something that I think is a little hard for us because it's like, I wish I can do more here to really drive it home for folks. But so much of this is about human behavior and psychology and what we can do to nudge people in the direction that we want them to be in. One of the things that we've heard from community members, we've definitely heard this from MCOs, et cetera, is like how they can help their residents. So I'm going to give you opportunity to give a short PSA here on how folks can help individuals who they know should be covered, but for whatever reason hasn't gone through the process yet.
I'm sure. And I just will restate something you said earlier that I also firmly believe. I think this is like, it's going to take all of us. I really do think it's the messaging, and whether it's, your neighbor, maybe an older adult, you see an aide going in their house, that might mean they have a good chance that they're on Medicaid, and just touching base with them. So I think it's part of it's getting the word out, which I do think overall has been going pretty well. But once you do that, it's like, connecting to folks of like, you might get an envelope with a green mark on it. You get that envelope with a green mark on it, you need to look at it. That's important. That's your health insurance coverage. You need to respond to that. Making sure folks have the correct phone numbers, you can connect with us, knowing the different ways that you can ask questions or submit your renewal packets, whether it's district direct, going to an ESA service center, doing it by phone, fax, I think still is an option, and mail. And then also, if anyone has questions as a beneficiary of what to do, we have a monthly beneficiary town hall now where we really just try to make it a safe space for beneficiaries to come forward and ask whatever questions they may have. And then we'll follow up directly if there's a particular issue with the case. Our bi-weekly stakeholder community meetings where, we're just trying to make sure we get any and all information out to folks, particularly if something goes wrong, what has gone wrong, how to fix it, or we're in the process of trying to fix it. And then if folks have an interest in better supporting their neighbors in terms of actually better understanding how to renew, we have a monthly training for anyone who wants to learn how to renew Medicaid. And this is focused more on assisting someone. Our next one will be at the end of the month. I think at 2:30, maybe, I think it's on the 29th. We can get that date for you. But at the end of the day, we just need folks to act now so they can stay covered.
Thank you so much. The report that you all send to us, is that something that you all have made available on your website?
Yes, it should be. That's
Okay.
the intent.
Okay.
It should be posted. I just haven't looked at it for myself, but we'll double check that.
Okay.
I can
just wanna-
confirm it's there,
Okay.
both iterations.
Thank you. Eugene's like, no, it is definitely there. I just want to encourage folks to take a look at the report, particularly the second one. Ms. April, your team has done some more specific data cuts about some of the demographic information. And, if folks are interested in learning about more of the characteristics in terms of those who either have been non-responsive or been determined ineligible, all of that information is in the report. It is not specifically on the dashboard. So I just want to be very clear. You have to go to the report to get more of the demographic breakdown information. Just as a follow-up, so
we're going to talk about some of the follow-ups, and I'm done with questions. Councilmember Gray, if you're still with us, do you have any questions before I wrap this up? Oh, okay. I think he had to rotate off. Okay, so if you all can follow up with us with the list of flexibilities that you have submitted to CMS, and have they provided a timeline on when you can expect to hear back?
They've been pretty expedient in their responses, usually within several days, couple weeks. Does that sound fair or not so fair?
Yeah, so they usually initially reach out to us just to confirm like our planning with the request flexibilities. There's some back and forth, and then probably within 3 weeks to a month, we have the formal approval letter to move forward.
Okay, it's not the 90-day plus for a state plan amendment.
Thank you. That was really where my heart,
That's
I was
what-
like, oh, we're gonna have to
No.
wait like 90 days to hear back from CMS.
They appreciate that.
So I think that's the only follow-up that I have from you all, because we've been in regular conversation and the dashboard and information. I still am going to nudge request that perhaps a twice a month update to the dashboard would be just very lovely for everybody to have that information. But we have a follow-up with health benefit exchange. What I have asked for them is a specific breakout in terms of they said they receive hundreds of names information from you all. I wanted to know thus far in this process, how many people were determined, oh, you're not supposed to be in this group. Like, oh no, hold on. You were mistakenly put in this population. And then how they went through and sort of determined otherwise, oh, this person is likely not eligible for coverage. Because I think for folks to go from, we know what, 1,800 people have been terminated for ineligibility, to then hearing, well, our health benefit exchange only ended up reaching out to 19 and then converting 4. That might give some people like, whoa, what's going on here? And so I think this bit of data will help clarify what's really happening in that front. And then I'm saying this out loud for folks to know within my team also, like, we're going to send a letter to Department of Human Services. I don't have jurisdiction over DHS. They are very much part of this process though. And I don't really want to wait 30 days to try to get them on a calendar to be a part of a hearing if I recess this and then bring them in. And so specifically my questions for them is going to be around staffing and processing, because I realize that for Magi folks, that's outside of your all's control. But there has to be some communications too. If they need help, this is the time to send up the red flag, not in December, when we have a large percentage of people who it's over the 45-day processing window. And I think if I'm remembering, in the report, there's a pie graph. There it is. So just for folks to know, we've been good. About half of pending renewals have been processed in 30 days or less. Great. Let's woohoo. But we do have about 31% that has been pending for 31 to 60 days, 7% that has been taking more than 90 days. And so, we got to work on this, because I don't want DC to be pinged by CMS for our lack of processing in the same way that we get pinged for CMS in terms of our lack of processing for SNAP. And so that's in the DHS warehouse. And so we're going to follow up with them on that in particular. All right, let me do my little closing here. I want to express my gratitude to all the witnesses who testified today. Obviously the team from Healthcare Finance, but also our public witnesses, et cetera. It is clear from our multiple hearings on this topic that we are very much united in our desire to have all eligible district residents renew their Medicaid coverage and to connect residents who aren't eligible with Medicaid to a health insurance provider, whether through our exchange or other means. I appreciate the effort that our agencies are putting in to make sure that district residents have the appropriate health insurance coverage, and that we're all working together to build on our successes and overcome some challenges to reach the goals that we all have. I want to reiterate my plea to any district residents from the beginning of the hearing. If you have received a renewal notice, you'll know it's a renewal notice because there's a green bar on the envelope. Please, please, please open it up, complete it, submit your renewal application You can log on to districtdirect.dc.gov. Make sure your information is up to date. And then if you do need assistance, you can call 202-727-5355. If your circumstances have changed, all of that information is in there as well, but we do need to hear from you because the non-responsive, I think that's the part that's giving us a little bit of heartburn. For anyone who was not able to attend or speak at today's hearing, we are accepting public testimony until Monday, September 25th at 5 p.m. I'll say it again. The council is changing. We're getting better with our technology. We have a new hearing management system. So if you go to the council website, dccouncil.gov/hearings, click on this hearing, and then you could just upload your testimony right there. And actually the greatness about it is that it makes it publicly available for everyone else to also read their testimony as well. So I will say, please do that by the 25th. If for whatever reason you still want to call us, you can call us and leave a voicemail with your testimony at 202-430-6046. If you leave a voicemail, please remember to spell your first and last name for the record and speak slowly. There being no further business before the committee at this time, this roundtable is adjourned. I think our next hearing is on the 21st. Yes, on social work licensing bill. I think that is correct. So the time is now 12:07 p.m. and this hearing is adjourned. Thank you.